Good morning everyone. I am Dr. Thangabalu from Department of Orthodontics, Assistant Professor. Today I am going to take a class on white spot enamel lesion. So these are the contents we are going to cover today. Definitions, etiology, scoring method and classification, and various diagnostic methods, prevention and treatment, and conclusion. So on introduction, white spot enamel lesion is one of the adverse effects that will occur during a orthodontic treatment. There are the various adverse effects. It's not an adverse effect of orthodontic treatment. Due to some carelessness during orthodontic treatment, there will be a occurrence of various adverse effects. I can name that. That is called as orthodontic scars. So what is orthodontic scars? Orthodontic scars majorly include three adverse effects. That's first one is white spot enamel lesion, and second one is external apical root resorption, and third one is gingival resin. So today we are going to briefly discuss about the white spot enamel lesion during a orthodontic treatment. So on introduction, the aesthetic is often a main reason that patients seek a orthodontic treatment. So first reason patient seeking a orthodontic treatment is aesthetic is the major concern. And during a orthodontic treatment, we used to do a banding, bonding, and the brackets, wire. Such things limits the patient in maintaining the good oral hygiene. So that will leads to occurrence of the white spot enamel lesion. So the banding and bonding of orthodontic appliances to teeth increase the number of plaque retention sites, and as a result, the oral hygiene becomes more difficult. So moreover, there are changes in plaque microbiota and obstacles to natural cleansing mechanism, including a salivary flow and buccal and labial musculature. So this will lead to the lowering of pH, that's a salivary pH. That is, we call it as a critical pH, that is 5. The pH when go below 5, that is a critical pH, during orthodontic treatment leads to the occurrence of the white spot lesion. So the low pH of plaque adjacent to the orthodontic brackets hinders the remineralization process, and decalcification of enamel can occur. As enamel translucency is a direct related to the degree of mineralization, initial enamel demineralization usually manifests itself clinically as a white spot enamel lesion. So in this topic, we are going to discuss about the etiology, how we are going to diagnosis, prevention and treatment of the white spot enamel lesion. So first we look at the classification of white lesions on the enamel. It's not a white spot lesion on enamel, it's white. What are the white lesions that can occur on the enamel? So there is majorly three by Bishara. There is classification given by Bishara. So first one is a dental fluorosis, and second one is a non-fluoride. It's not due to the fluoride, maybe a developmental disturbance. And third one is a white spot enamel lesions that occur during a orthodontic treatment. So first, how can we differentiate these three things? So first we look at the dental fluorosis. In the picture you can see that it will be color in white or yellowish lesions that are not well defined. It's not well defined. You can see that borders are not well defined. But in case in developmental disturbance, you can see that there is a definitive shape, and it's particularly present in the occlusal 1/3 of the teeth. So, and final one is a white spot enamel lesion. You can see that it mostly commonly present under the brackets or loose bands. So you can easily visualize that the presence of white spot enamel lesions under the brackets. You can see that this is an area where there occurrence of white spot enamel lesions. These are the things. So this is the basic classification of white spot enamel lesions given by Bishara. So first we come to the definition. So what is white spot lesion? By definition, white spot lesion has been defined as a subsurface enamel porosity from caries demineralization that present itself as a milky white opacity when located on the smooth surface. So white spot enamel lesion is nothing but a early incipient caries. It's a starting stage of the dental caries. So what are the risk factors in the development of the white spot enamel lesion? According to Julian, author, it's given in 2013. He given 5 risk factors in occurrence of the white spot enamel lesions. So he given that first one is a treatment time. That is when the orthodontic treatment is excess of 36 months, that is more than 3 years. That's one of the risk factor for occurrence of the white spot enamel lesion. So we try to complete or reduce the treatment duration before 3 years. As long as the treatment is going, the chances for occurrence of white spot enamel lesions is more. So second one is a teeth without fluorosis. Few people, few geographical locations are not exposed to the fluorides. The 1 ppm of fluoride is necessary for everyone, but when the patient is not exposed to the fluoride content, so that will also leads to non-exposed fluorides, that one of the risk factors for occurrence of the white spot enamel lesion. And third one is it's a universal, that's a patient with the poor oral hygiene. If the patient is not maintained oral hygiene properly, that's really one of the major risk factor for occurrence of the white spot enamel lesion. And fourth one is a patient whose oral hygiene declined during treatment. Few patients have a good oral hygiene before start of the orthodontic treatment, but few patients due to because of the brackets and the bands of wires, they are not well aware, or that their oral hygiene will be declined during the treatment. So that kind of patients we have to motivate them to maintain a proper oral hygiene. And final one is a pre-existing white spot enamel lesions. For example, few patients will be present with the white spot enamel lesion before orthodontic treatment itself. So there are all high risk factors. These 5 are the high risk factors, significant risk factors for the development of the enamel lesion. So what is the basic mechanism behind the occurrence of the white spot lesion? It's nothing but a salivary system has a own buffering capacity. It will maintain the pH properly. But when the fixed orthodontic appliance therapy, the brackets and wires, such things are started. So the pH, because of the we are creating a more plaque adhesive sites. The deposition of plaques and food particles will be more. We are creating more adhesive sites. So that leads to the lowering the pH, and once the pH is lowered, our buffering capacity of saliva is reduced, and that leads to the demineralization of the enamel. So according to author Gwinnett and Sein in 1979, he stated that fixed orthodontic appliances induce a rapid increase in the volume of a dental plaque. And one more author, Chatterjee and Kleinberg in 1979, the plaque in orthodontic patients had a resting pH lower than in the non-orthodontic subjects. He compared the orthodontics versus non-orthodontic patients. He stated that the orthodontic patients significantly result in a pH is significantly reduced when compared to the non-orthodontic patients. So most common negative side effect of the fixed appliance is the development of incipient caries lesion around the brackets and veins, that is a white spot enamel lesion. Since the orthodontic appliances make plaque removal more difficult, patients are more susceptible to the caries lesion. As I told earlier, because of bands and brackets, wires, patients have a limitation in maintaining the oral hygiene. So that will lead to the development of the white spot enamel lesion. So once we started orthodontic treatment, how long it will take to occur the white spot enamel lesion? That's an important question. So white spot enamel lesion can become noticeable around the brackets of lenses within 1 month of the bracket placement, although the formation of regular caries usually take at least 6 months. Generally, dental caries usually take at least 6 months. From day 1 to at least it will take a 6 months to notice dental caries in the mouth. But in orthodontic patients, you can see that within 28 days, you can see a white spot enamel lesions on the patient's mouth. So as I told earlier, this is the flow chart, how the demineralization and remineralization. This is the basic buffering capacity of the saliva. It will give, for example, first we can see that during fixed orthodontic appliance therapy, 2 things will happen, either a favorable or unfavorable things. Favorable means increased salivary fluoride, increased salivary pH and buffering capacity. That will happen once we maintain the proper oral hygiene. If it is favorable, so the tooth will get demineralized and remineralized in the proper rate. Once the unfavorable changes, for example, increased plaque retention, and there is a production of more acids, that will lead to the that are all unfavorable changes, that will lead to reduce the pH of the saliva. So that will be due to what are the major bacteria, if we ask. That's a major is 2 acidogenic bacteria, that is Streptococcus mutans and Lactobacilli. Streptococcus mutans is acidogenic bacteria that will initially produce dental caries, and it will progress by the Lactobacilli bacteria. So these 2 things, these acidogenic bacteria is one of the main reason for occurrence of the white spot enamel lesion. So as of now we discussed about the basics, how white spot lesion is occurring, what are the etiology. Now we are going to study about the diagnostic methods. What are the various diagnostic methods? So we have basically have 2 types. One is a qualitative method and is a quantitative method. In qualitative method, just we are going to see about, we classify like based on the severity, mild, moderate or severe, like that. In quantitative method, we are going to tell in detail about the how much the enamel is lost. In quantity, we are going to quantify the structural loss. So in these two basic methods, we will first see about the visual examination. We are not going to discuss in detail about this. Only two common things. One is visual examination, and in quantitative methods, diagnodent method. So these two we are going to a little bit briefly we are going to discuss about. So first one is the visual examination. Visual examination is nothing but once you properly dry the teeth, and you are going to visually examine the teeth. If there is any discoloration, any decalcification, you are obviously going to look at that. That how we are going to classify. There is one method called Gorelick scoring system. It was given in 1982. So he given the 4 score criteria. Score 1, we can see that this is a clinical picture, and as well as this is pictures for a diagrammatic representation. So score 1, that is no white spot lesion and decalcification. We can see that nothing is there. And score 2, that is a slight white spot formation. We can say that slight white spot formation or decalcification in one area only. Clinically we can say that here slight decalcifications in the gingival area. So what is a score 3? Score 3 is the severe white spot formation or many areas of the decalcification. We can see score 3 is a severe formation, and score 4 is a excessive. Excessive means how can we say that there will be a formation of cavity. It's advantage stages of the white spot enamel lesion. So this is a basic scoring system given by Gorelick in 1982 for a visual examination. There are a lot of methods, but we are discussed only about Gorelick system. So second one is a quantitative method. This is a laser fluorescence diagnose method. So how it's going to work? In the presence of the caries, fluorescence increase and changes is registered as an increased digital number. So this is like a torchlight. It works on the fluorescence. When the there is a enamel structure loss, in the presence of bacteria, that will show the changes in the number. I will show the diagram later. So what is the mechanism? The mechanism underlying is the presumed to be result from integration of bacterial metabolites rather than the crystalline disintegration. It works on basically the bacterial metabolites rather than the crystalline disintegrations. So this is the scoring for a diagnose device. 0 to 14, if it shows in the diagnose device, that is absence of caries, and caries is present in the enamel 15 to 20. If it is 21 to 99, it's progressed. It shows a progress, that is present in the dentin. So one of the major disadvantage in the using the diagnosant is it can be affected by the presence of calculus or plague or any bacterial any bacteria. This can affect the performance of the diagnostic device. So this is a picture, first picture we can see this is the number showing. This is a diagnostic tip. So a systematic review, they reviewed the performance of a diagnostic device for detecting the caries, published in 2004. They have concluded that there is insufficient evidence to support the use of this device as a principal means of caries diagnosis in clinical practice. So in clinical practice, diagnosant is not a perfect device. Means we cannot completely rely on the performance of the diagnosant. So we have to combine other methods and visual examination. We have to combine other method also to detect the white spot enamel lesion. So now we are going to discuss about the prevention and management of the white spot lesion. So it's a very important, as we told earlier, white spot enamel lesion is one of the adverse effect. Okay, so we have to prevent that before the occurrence. So in this topic, we are going to discuss in two separate headings. That is, one is occurrence of white spot enamel lesion during orthodontic treatment. Means its white spot enamel lesion is not occurred during orthodontic treatment. If we are not properly maintain the oral hygiene, definitely it will going to occur. So we are first and foremost aim is prevention of white spot enamel lesion, and second is once the white spot enamel lesion is occurred, what we are going to do. So these are the two major headings we are going to discuss about today. So first one is during orthodontic treatment. So once the patient is coming, we are going to start orthodontic treatment, fixed appliance therapy. They are going to wear a fixed appliance therapy for 1.5 years, 2 years. what are the instruction, what are the preventive measures we are going to take. First we are going to see about the preventive measures. So first one is the maintenance of the proper oral hygiene, and second one is the fluoridated things. We will explain, discuss heading by heading later. So first one is oral hygiene control. The first and foremost measure is maintenance of the proper oral hygiene. The first important prophylactic measure to prevent the occurrence of white spot enamel lesion in orthodontic patient is implementing a good oral hygiene regimen, including a proper tooth brushing with the fluoridated dentifrice. Usually we will have a daily routine life. What all the paste we are using, that are all the fluoridated, commonly used toothpastes or always already fluoridated one. So proper advising of tooth brushing techniques and twice a day advising a toothbrushing and improve or maintain the proper oral hygiene. So the dentifrice typically contain either sodium fluoride, monofluorophosphate, stannous fluoride, amine fluoride, or a combination of these components. So in commonly what are the toothpaste we are using, these will contain a fluorides. So for orthodontic patients, what are the special precautions taken to orthodontic patient is should not below the 0.1% in dentifrices, because orthodontic patients are more commonly prone for occurrence of white spot enamel lesions. So in these patients, the fluoride percentage should not be below the 0.1%. So because we need a appropriate level of fluoride. So when fluoride ions are incorporated into the surface of enamel, a fluoride crystal structure is formed that has a lower solubility in the oral environment compared with the hydroxyapatite. So next one is topical fluorides. So topical fluorides means we are not going to give systematically. We are going to apply topically, or going to it's not a systematic, it's just going to give only external. So these are the various techniques like mouthwashes. We can give mouthwashes, gels, and fluoridated toothpaste, fluoride varnishes, and fluoride in bonding agents. The first four things are general, and fifth one, fluoride in bonding agents, is we are going to incorporate fluorides in bonding agents like adhesives. We are going to incorporate. So white spot enamel lesions or dental caries can be impeded at an early stage by the fluoride ions through the several mechanics. In early stages, the fluoride has a capacity to impede or to arrest the caries or prevent the progression of the caries. So what are the methods? First one is, as I told earlier, Streptococcus mutans is an acidogenic bacteria. It's going to produce an acid that will lower the pH, that lead to demineralization of the enamel. So first step, it's going to inhibit the production of acid. Okay, so we are by inhibiting that, we are going to maintain the proper pH of the saliva. So second one is alteration of composition of the bacterial flora or metabolic activity of the microorganism. Is going to affect the microbial flora, affect the metabolism of microbial flora. And third one is decreasing the demineralization. So as I told earlier, it's inhibit the productions of acids and bacteria. So it's obviously going to increase the remineralization capacity and decrease the demineralization. So first one is fluoride mouth rinses. Mouth rinses is nothing but daily what we are advising to the patients for it should contain a fluoridated mouthwash. Fluoride used daily have been served significantly reduce the enamel lesion formation beneath the pens. So according to Bishara, he advised that the 0.05% sodium fluoride mouthwash has significantly effective in reducing the occurrence of the white spot lesion. So that should be used daily. So various authors has evaluated the efficacy of fluoridated mouthwash. For example, Hedgefield, he advocated the APF mouth rinse wash to make the enamel more resistant to the orthodontic induced decalcification. And Geiger et al., he reported that there is a 25% reduction in the number of white spot enamel lesion using the fluoride rinse. It was also found that following 2 weeks of usage of sodium fluoride, as I told earlier, 0.05% sodium fluoride mouth rinse with only once rinse per day, it increased the fluoride concentration in the saliva. Significantly, it increased the fluoride concentration of the saliva. Then a daily mouth rinse of sodium fluoride 0.05% or weekly sodium fluoride, that is the percentage will differ. 0.2% will be used for weekly mouth rinse with the AFP gel have been found to reduce the incidence of enamel demineralization during the orthodontic fixed appliance therapy. So if the patient is not compliant, they are not properly, usually the fixed appliance therapy, usually kids will, adolescents patients will have, so few patients may be compliant, few patients may not be compliant. So what can we do? Or any challenged, physically challenged patients, or with any systemic disease, and that kind of patients, what are the alternatives? The alternatives to the normal oral hygiene procedures is application of fluoride varnishes. So what is the benefits of the varnishes? Varnishes is a long lasting, it will produce the fluoride for long lasting time, at least for more than 12 hours of a time. So it will nothing but it will be like increased viscosity, means more viscosity, so that we have to apply on dried tooth surfaces. It has a long lasting effect. It will release the fluoride for more than 12 hours. So that will be beneficial in the patients, those who are not compliant. So as I told earlier, these are the few studies. Vivaldi Rodriguez et al. 2006. He reported the application of fluoride varnish resulted in a 44.3% reduction in the enamel demineralization in orthodontic patients. So final one is fluoride in bonding agents. So we as of now, it's depend upon the whatever we discussed is on the patient's hand. Now it's in the clinician hand. So because we are going to clinician is going to use what type of bonding agents, such things. So there is in commercially available fluoridated bonding agents are available. So during orthodontic treatment makes the patient an increased caries risk for a prolonged period time. As a result, a continuous fluoride release from the bonding system around the bracket base would be extremely beneficial. So there is some recent developments in incorporation of fluoride in the bonding agents. There is also pros and cons, because when we add a fluoride in the bonding agent, it's going to definitely affect the chemical reactions of the bonding agents and bond strength. There's a lot of things to be concerned. The development is going, but a recent study stated that there is no adverse effect or any change in bond strength while adding a fluoride. So it will be beneficial while adding a fluoride component in the adhesives, because it's going to release the fluoride under the bracket base. So that is the most common site for occurrence of the white spot enamel lesion. So to increase the strength, resin particles have been introduced. So we are going to study about there's one study published in Journal of Orthodontics in 2015. A study was done by Dr. Ashok Kumar Jana. He studied the efficacy of resin modified GIC varnish in the prevention of white spot enamel lesion during a comprehensive orthodontic treatment. It's a split mode study. So he concluded that use of resin modified glass ionomer cement varnish during the comprehensive orthodontic treatment as a modest beneficial in the prevention of the white spot enamel lesion. So he advised the resin modified glass ionomer cement varnish application during the orthodontic treatment. And one more study by Dr. Sombir Singh, it was published in 2016. So he studied the effect of various remineralizing agent on outcome of the post-orthodontic white spot enamel lesion. It's a clinical trial. After orthodontic treatment, how the white spot lesion is reduced. He studied about the post-orthodontic treatment, its outcome of post-orthodontic white spot enamel lesion. He studied in 46 subjects. So he classified on a basis of usage of the toothpaste and varnishes and CPP, ACP. See, majorly classified into 3 groups. So after he studied about the various usage of varnishes, toothpaste, he given a conclusion that the use of 1000 ppm of fluoride toothpaste twice daily was effective in remineralization of post-orthodontic white spot enamel lesion. So he advised that 1000 ppm of fluoridated toothpaste twice a daily is more effective in remineralization of a post-orthodontic white spot enamel lesions. And use of 5% sodium fluoride varnish in addition to above method, they are using a usage of varnishes 5% sodium fluoride had no additional beneficial effect. So he given that there is no additional beneficial effect of using a varnishes when compared to the simply using a 1000 ppm of fluoridated toothpaste. Twice daily use of CPP, ACP plus cream along with the twice daily use of 1000 ppm of fluoride toothpaste had no added benefit in the remineralization of post-orthodontic white spot lesion. So from this study, what we are going to do, simply using of fluoridated toothpaste which should contain 1000 ppm of fluoride. Fluoride will really helpful and more effective in remineralization of the white spot enamel lesion. So now we are going to see about the treatment of white spot enamel lesions. As of now, we discussed about the prevention. Now, once the enamel lesion is occurred, what we are going to do? Once enamel lesion is occurred, it's very difficult in remineralization. It's depend upon the only mild white spot enamel lesion can be remineralized. Once it the severity is increased, it's definitely it will be more difficult to remineralize the enamel structure. So in this kind of patients, we have to do a camouflage treatment. That means we are going to mask the internal problems. So first we will see about the remineralization. After an orthodontic, first step is whatever the severity, we have to attempt to remineralize the lost enamel structure. So first approach is eliminate the white spot enamel lesion is remineralization. So there are the several professionally and home applied products in different forms, solution or varnishes, creams, as already we discussed, that are for the topical remineralization. So why? Because they are all contain the fluorides, so that will help to increase the remineralization, but it depends upon the severity. The success is depend upon the severity. If it is more severe, the success will be less. If it is a starting or initial stage, there will be a good result. So we can see that these are the white spot lesions after debonding. In these pictures we can see that. So white spot enamel lesions, if it is present following orthodontic treatment, it advisable to allow for a slower calcium and fluoride ion penetrations of the white spot enamel lesions from saliva or through the application of lower concentration of the fluoride. So we can externally apply a fluorides, or we can wait for sometimes for the penetrations of the fluorides into the white spot enamel lesions. So for a remineralization. So this approach, this remineralization approach may ultimately produce more aesthetically favorable results. So we can see that when compared to the previous pictures, after remineralization, we can see that there is a great improvement in the remineralization of the enamel. So we can appreciate in these diagrams. So once remineralization is failed, if the patient is unable to remineralize the lost structures, the next will be a bleaching. What's bleaching? So fluoride, in these conditions we are going to camouflage the internal problems. We are just going to give a mask to the external layer of the enamel. So the defect will be present inside, and externally we are going to apply a mask. So that is the purpose of this procedure, is to camouflage mild or moderate fluorosis or white spot enamel lesion by whitening the surrounding enamel surfaces. You can see that picture A shows the white spot enamel lesion, and picture B we can see that is after bleaching. We are just going to do whitening of the enamel structure. So this is not this is only a non-invasive procedure. So this is also advisable in the treatment of white spot enamel lesion. And final one is a microabrasion. So microabrasion along with the bleaching technique is an active method for treatment of post-orthodontic white spot enamel lesion while depth of the lesion is less than 2 mm. So we advise the bleaching technique along with the microabrasion. Microabrasion means we are just going to we use the burrs and creating a slight abrasions that will help in penetrating of the fluorides. So this, when it can be advisable, is the white spot enamel lesion depth of the lesion should be less than 0.2 mm. So after debonding of the brackets, a microabrasion plays a good role by process of salivary remineralization and continuous surface abrasion for improving the lesion because of its invasive nature. And final one is a resin infiltration. A low viscosity resin is used to infiltrate the white spot enamel lesion after a completion of several steps like etching, rinsing, drying, and so. Once we do all the etching process and applications of low viscosity resin, that we are going to infiltrate in the defects created by the white spot enamel lesion. So that is a final option. It has a moderate success. After etching, we are going to apply that resin. That is a low viscosity. So because of viscosity, it will capillary effect, it will penetrate into the defect easily. So which makes the enamel surface more permeable for triethylene glycol dimethyl based resin to pass into the underlying porous structure, cause to mask the white spot enamel lesion as well as reinforcing the prismatic enamel structure. So this is the last shot. Last shot is a porcelain veneers. Porcelain veneer means we are going to mask. We are just remove the defect structure and we are going to place some porcelain veneers, that is masking. This is also final procedure. So is a systematic review. They have studied the intervention for orthodontically induced white spot enamel lesions. So they have concluded that among the available treatments, the monthly use of 22,600 ppm fluoride varnish or 5% sodium fluoride seems to be best viable protocol to augment daily use of fluoride entries in terms of both reducing the white spot lesion area and to increasing its aesthetic appearance as well. So they have advised that usage of fluoridated varnish or fluoridated mouthwash that will be beneficial in preventing the white spot enamel lesion. So what are the instructions to be given to the patients after starting a fixed appliance therapy is to maintain a proper oral hygiene. That is first and foremost important in every patient, that especially in orthodontic patients it's very difficult to maintain the oral hygiene. So we have to advise a patient to maintain a proper oral hygiene and proper brushing after every meal and mouth rinses. As I told earlier, 0.05% of sodium fluoride is advisable daily. Once per day is enough. And topical fluoride applications like varnishes that can be applied. And chewing gum. Nowadays chewing gum with the xylitol are available that will increase the salivary flow rate. So that will be also helpful in maintaining the good oral hygiene. So we concluded about the topic. So decalcification of enamel surface adjacent to the fixed orthodontic appliance is an important and prevalent iatrogenic effect of orthodontic therapy. The banding and bonding of orthodontic appliance to teeth increase the number of plaque retention sites, and as a result optimal oral hygiene became very difficult. In general, the treatment of white spot lesions should begin with the most conservative approaches. If such approaches is failed, do not resolve the problem to the clinician certification. More aggressive treatment modalities can be pursued if the patient desires it. So from today's topic we are going to learn is we have to definitely prevent the occurrence of the white spot enamel lesion. So orthodontic during orthodontic treatment, three major adverse effect that will occur. That is, we already discussed about the orthodontic scare. That is, one is white spot enamel lesion, second one is external apical root reception, third is gingival recession. So today we discussed about the white spot enamel lesions, about the etiology and what are the risk factors and the classification of white spot enamel lesions, and what are the various methods in diagnosing the white spot enamel lesion, and finally we discussed about the prevention of white spot enamel lesions, and after that we finally discuss about that once the white spot enamel lesion is occurred, how to treat that in a systemic manner. From always we have to start from the conservative approaches to the more aggressive. That depends upon the patients. Thank you for patiently waiting for my class.